large scale. So what I'm going to talk is from the National Cancer Registry Program, which collects data on all cancers. On the left side, you see the population-based cancer registries. There are 38 of them spread out across the country. And on the right side, there are around 230 hospital-based cancer registries which we are running. The results which I will present are from 28 population-based cancer registries and 96 hospital-based cancer registries. This is the projection we have made for the year 2025 for all sites of cancer, but we picked up the top ones, and for this conference we can look at the kind of burden we are expecting of new cases of prostate cancer. These are the typical urological cancers that we will be discussing. In the global distribution of urological cancers, the WHO Southeast Asia presents the least incidence, age standardized incidence rates of all urological cancers, whether in men or in women. And when we look at by select countries, men and women, in males you see India at the bottom, but we are a little higher in female incidence of cancers as compared to some similar countries around us. Now coming to India, what else do we see? So this is the 28 population-based cancer registries, and you can see the male-female distribution. The lower incidence rates among females, and there is a higher distribution of urological cancers occurring in registries which are predominantly in the urban areas. If you look at registry-wise proportion of urological cancers in males, prostate cancer accounts for more than 40% of all urological cancers in many of the urban registries, and a higher proportion of penile cancers and some testicular cancers are seen in the rural registries and those from the northeastern parts of our country. In the females, again, we see that bladder cancer is leading site for urological cancer. These are the age-specific rates for urological cancers total in combined, and in males, prostate cancer leads the highest incidence rates. The rates start dramatically increasing after the age of 55 years. And whereas in females, you see that it is the bladder cancer which starts much earlier, at least a decade before what we see in men. These are some of the trends for site-wise cancers. Males, bladder, females, bladder, and these are for select 5 registries which give us at least 30 years of longitudinal data. So the National Cancer Registry Program was started in 1981, and we have now 42 years of data available. The next round of analysis is underway, and we do hope by the end of this year we will be bringing out the results from many more registries and much updated statistics. This is for kidneys for men and women. This is for prostate, testis, and penile cancers. And so the decline in penile cancers obviously corroborates not with medical interventions, but more with our social determinants, whether it is hygiene, whether it is reduction in any HPV-related cancers, and all those kind of issues. So what are we going to see in the future? And this is the burden that you all should be aware of. The total urological cancers are projected to rise by 7% over the next 3 years or so if we do not intervene at now. And this will be 12.6% of all sites within the male cancer. So this is for males. The prostate cancer is now almost the 3rd commonest cancer in men, followed by bladder cancer, kidney and renal pelvis cancers. Whereas in females, it will be the urinary bladder cancer, which will be providing us with the highest rise of around 7.5% and will constitute 1.6% of all female cancers. When we look at the clinical scenario from our hospital-based registries, and we see the distribution of cancers by localized, loco-regional spread, distant metastasis, we see higher proportions of distant metastasis as well as loco-regional. And for a comparator, we are showing what happens in the United States of America, where we see such high proportions of localized stage at diagnosis. So there is a lot of public health relevance at the stage at which cancers are diagnosed. And this gets reflected because we offer multimodal treatments much more. So cost of treatments, complexities of treatments, and the toxicities of treatment would be much higher if we have such loco-regional and distant metastatic cancers presenting to us. We have a higher mortality to incidence ratios. This is a very sensitive marker for mortality in cancer registries. And we compared it with USA and with Europe. And probably the reason lies because we see a lot of loco-regional and distant spread metastatic cancers, urological cancers. So this is also something which we need to keep in mind while as we work in hospitals as clinicians, but how does it impact? So what you discuss here after a few years or decades should have relevance in making a public health impact or a change, and how can we downstage some of the urological cancers. Can you give us a program, can you give us in a programmatic mode screening tools, early diagnostic tools which can be implemented, because currently the country is only implementing breast, cervix and oral cancer screening. So to summarize, the burden of urological cancers in India is low compared to the Western countries, but has a high mortality to incidence ratio. Males are prone for development of urological cancers compared to females, and by 2025 they would constitute 12.5% of all total male cancers. Prostate and kidney cancers show more of an urban phenomena and a positive trend in the rise, whereas penile and testicular cancers are more of a rural phenomena with a declining trend. Prostate cancers are mainly diagnosed at advanced stages, and unimodality treatments are the most preferred compared to multimodality. And registries have their limitations. So whether we are collecting regional, local, distributive data, and some registries also include some non-invasive cancers. So that we have to tease it out. There are issues of variation in access to care and usage of advanced diagnostic facilities, the screening programs, early diagnostic tools, and exposure to risk factors is also something which will drive the cancer incidence ratios. So thank you very much for your kind attention, and I do hope that we will be able to stir up some more discussion and debate around it.
Yeah. I have a question, sir. So do you have a measure of how many cancers are underreported or non-reported?
So these are real world registries. These are not clinical trial registries. In a real world, what you put into us is what we record. And many of the hospital-based HPCRs people are sitting here. You may not be the direct investigator, but your hospital is part of it. Representation of urological cancers is lower than what is driven by other solid tumors. So underrepresentation, underreporting is a constant challenge for any real world registries.
Good morning.
Yes, please.
Yeah, I want to ask two questions. Urological cancer, what we are finding now as a second cancer in last decade or so, that's one. Second is, what is the distribution of tobacco-related versus non-tobacco-related? And are you finding any changes in that?
So tobacco-related cancers constitute almost 40 to 50% of all cancers. So for many of these urological cancers are also listed as tobacco-related cancers. So exposures is something which will continue to drive the cancer incidence.
And what about second urological tumors as second malignancy? Patients have survived the first malignancy and now coming back, he's living longer these
So
days.
we have not yet analyzed multiple primaries, but we will be doing that. That is one thing on our agenda, looking at multiple primaries.
Can we have that outcome slide, please? That comparison of India versus Europe versus USA. If you can have the third slide backwards.
Can you
And-
put on the presentation, please?
And in the interim, I just wanted to ask this question. So why are we finding more bladder cancers in women? Is this an after effect of what J&K sir was cervical cancer radiotherapy causing bladder cancers now?
The console over there. Can you put on sir's presentation, please? Yeah.
There was one comparing India to, I just wanted to understand the meaning of those numbers. There was one mortality,
Or could it be just an under-reporting
This
of bladder in women earlier? Under-reporting of bladder in women earlier, which is now getting reported more.
But these are same cancer registries that have been there for the last, since 1981. So we are only presenting 28 out of the 38 cancer registries.
No. This data is, this is from 28 out of 38.
Yes. So this one, if we look at the testicular cancer one, which is M by, so that is mortality to incidence. When we say 0.3, that means out of 100 people, 0.3 people are dying. Is that right way of looking at it?
So you have a mortality figure and divided by the incidence of that particular year and arrive at the ratio. So this is a sensitivity marker for the registry to pick up mortality and incidence. So the cancers which are giving us a higher mortality will have a higher MI ratio.
Sorry. So if you see the USA,
This is not case fatality rate.
not case fatality.
No.
Yeah,
This is
that's
not
because
case-
it's 0 for USA.
Yeah. So this is not case fatality rates.
Okay.
So 0 means that they have not reported mortality in testicular cancers.
Okay.
So,
The registration system.
Dr. Prashant, thank you once again for, I think every slide was an eye-opener. Now, there's clearly a concern for prostate specifically because there seems to be an increasing incidence. It has taken decades for screening trials, policies, and with the ebbs and flows to come to a point. Now, if either we start our own screening trials and give an answer after 2 decades, or if we had to follow some of the guidelines, either the American ones or say the British ones or the European ones, which one, I mean, where do you think we should adopt things from, the policies from? Because typically what's happening is that in tier 2 and even in rural places in India, there's like a spate of labs coming in and everybody is doing a PSA without a very unregulated PSA, without knowing the importance of it actually. So there has to be some policy from the health policy makers about the doing of or testing of PSAs here.
Well, testing of PSA is a clinically driven decision, so policy makers may not have a direct control over it. But certainly, if you all work and give us, so you gave us, TMH gave us VIA for cervical cancer, isn't it? So
20 years.
you gave us, there was consensus that clinical breast examination in a public health program is better than mammography. So give us some similar. So that is why we are stuck with colorectal cancer screening. We don't have a tool which will work across billions of people and across all settings, and having a higher sensitivity and specificity. So those are the issues which, if you can work around and give us.
Thank you,
Last
sir.
question.
Thank you, sir, for excellent presentation. See, in a public health setting, when you want to handle the public health problem, you need a good data. So, sir, what message you will give to the clinician to strengthen the cancer registry in Indian setup? Because I found I'm running 10 registries from Tata Memorial Hospital, and we always find difficult to get the data from the clinician. So, can you please?
So the name is hospital-based cancer registry. It is not departmental-based cancer registry. And so the way we work is we invite the or we communicate with the head of the institution to nominate somebody as a principal investigator for the HBCR. Supposing that nomination is somebody from radiation oncology. So what happens is that only patients who come to radiation oncology get registered. Medical oncology is second, surgical oncology. So the key is that whosoever is designated as the principal investigator must coordinate with all departments wherever cancer is diagnosed and treated. Could be orthopedics, could be ophthalmology, could be pediatrics. Like breast cancer, a lot of general surgeons are also operating. So they are missed out. Pediatric cancers, we are heavily underreporting because pediatricians themselves treat. They don't come to radiation oncology. So that is a gap which at hospital level one can fill up. And then we have to overcome our clinical egos. Why should I give data?
I'd like to just ask one question. Who is funding this? Government of India?
Yes.
And are they giving any incentive to these hospitals to submit these reports and all that?
So we are funding a lot of registries from ICMR side, but this cannot be an incessant, lifelong funding. It has to be part of systems data management so that it comes through as part of you. You all should feel the need for such a data. These are not research studies in the sense that it has a beginning and an end time. So 42 years of National Cancer Registry Program, another 100 years. How does any funding agency, you don't run hospitals asking some ICMR to fund nurses and paramedic staff. So institutional arrangements will have to be made, and cancer has to be made notifiable at national level. The day it is done, automatically everything will happen.
Thank you, Dr. Prashant
And just
Mathur.
30 seconds, one very important information.
Okay, sir.
Because in Globocan, if you see, particularly I am talking about penile cancer in Southeast Asia, especially SAARC region, at regional level, let's go beyond India, Nepal, Bangladesh, India, Pakistan, all over. In penile cancer, from global burden, we carry just 20% of the burden. And the mortality worldwide is more than 50% of the